First of all, I would like to thank University of Kyoto for inviting me for the third time, I think, to present in this prestigious conference. These slides are prepared by myself and Chiwan, so some credit should be given to her. Okay, when we talk about universal health coverage, there are various quotes given or made by health economists or experts in this area. But I just want to mention one quote by Nathan from Monash University. He said that among the Asian countries, Malaysia is actually doing very well, especially with regards to incidence of catastrophic medical expenditures. However, there are other things that needs to be improved, especially with regards to the quality and the services at the public hospitals in order to reduce the out-of-pocket expenditures. And referring to the evaluation or assessment conducted by Chua and Chia in 2012 on the Malaysian healthcare financing systems, in terms of the provisions of universal health coverage for the population, based on the WHO health financing strategy for the Asia-Pacific region, in which the framework had evaluated the Malaysian healthcare financing system and using the latest Malaysian data on health spending, which was obtained from the Malaysian National Health Account in 2008, Malaysia actually fared credibly with total health expenditure close to 5% of its GDP, out-of-pocket payment below 40% of total health expenditure, comprehensive social safety nets for vulnerable populations, and tax-based financing system that fundamentally poses as a national risk pool scheme for the population. In fact, I think with regards to this, we are not very different from Thailand. Only perhaps with regards to the financing, you will see later how we are different. So, in actual fact, Malaysia has actually achieved universal health coverage even in 1980. And this is not something that we made up. We made up. It's just it was stated by the World Bank in the World Bank Forum 2014. So let us now analyze whether this is true or not. Before that, I think it's quite crucial for me to present the health status of Malaysian. We know that Malaysia has achieved a fairly acceptable health status of a middle-income country, and to some extent it is comparable to the developed countries. And this is mainly due to the improvement in the socio-economic development, partly due to sustained investment into the social infrastructures such as the schools and health facilities. And if we look at the health status for 2013, life expectancy at birth for male 71.7 years and for female 76.4 years, which is actually not very much different from developed countries such as Japan. And the crude birth rate, as you could see, 17.8 per 1,000 population. And in fact, if you look at most of the list, this is we can say that this is fairly good. And the health status were achieved with a total expenditure for health as a percentage of GDP of only 4.75%. And the total expenditure amounted to about 11.7 billion US dollar. And with regards to the healthcare system in Malaysia, we actually have a dual healthcare system with the public and private sectors contribute to almost the same proportions. And the current health financing for public sectors actually rely heavily on taxation, while healthcare services are actually mainly provided by the government. Now, and this is very different from many other countries such as in Indonesia or even in Thailand. The public healthcare system has wide geographical coverage and provides comprehensive care at minimal fees. It's about only 1 ringgit Malaysia, which is about less than 30 cents of US. And there is rapid expansion of private healthcare sector, which match with the demand for private care And this is very much because the government of Malaysia has actually facilitated these private healthcare systems through healthcare tourism. And as you could see from the graph, the private sources of health financing with regards to the out-of-pocket payment, the percentage has increased over the years, but nevertheless, it is still less than 40%. And I think everywhere we can see there is increasing use of private care, especially with better per capita income of the people. And from 1930s to 2000s, there is increase in both the usage for public as well as private, and more so for the private. And with regards to paying for private care, the fees for private care obviously is higher than the public care, and this is paid for mainly through out-of-pocket payments, and the current out-of-pocket payments made up a third of the total health expenditures for healthcare in Malaysia. Now, when we talk about universal health coverage, WHO describes that the goal of UHC is to ensure that everyone obtains the health services they need without suffering financial hardships when paying for them. And it is thus a critical component of sustainable development and poverty reduction, and a key element to reduce social inequities. And that is what we are trying to do. And before we assess how Malaysia is doing with regards to USC, these were the components that we use in assessing, especially with regards to the use of two essential components, that is pertaining to access to effective healthcare as well as financial risk protection for health. So access to needed care, USC requires that the entire population receive healthcare that the people need. And for different assessment framework, we have used, such as examination of tracer indicator that is based on the immunization rates, the overall healthcare utilization rates, as well as healthcare utilization rates standardized for needs. So if we look at the childhood immunization coverage for Malaysia in 2012, almost all are more than 95%, except for HPV, because it's quite new. It's quite recent in Malaysia. But nevertheless, the coverage is still considered very good. And with regards to utilization of care, if we based on the data that we have for 2011, there were actually 4 outpatients visits per person and 86 hospital admissions per 1,000 persons. And therefore, we can say that there is equal utilization across all socio-economic status groups, whereby the poor are actually assessing the public health care, and so did the rich. But at the same time, the rich, they also assess the private health care. And poor households use more public services. And this is what we wanted, to make sure that the poor households are actually able to access the public health services. And if you look at the ranking, Malaysia is in the middle with regards to outpatient visits as well as with regards to hospital admissions. Now let's look at the financial risk protection for health. USC requires that the entire population be protected from undue financial hardship as a result of health payments. Therefore, households should not need to incur payments that are so high as to be considered catastrophic to their welfare and which may impoverish them. Thus, we had focused on out-of-pocket payment component in order to assess financial risk protection. When we talk about out-of-pocket payments, equity is the main concern. Okay, so out-of-pocket payments for healthcare are the least equitable manner of financing healthcare. So we try to make sure that the proportion for out-of-pocket payment should be as low as possible. And because reliance on out-of-pocket payment for health can actually jeopardize UHC, so there is more reason for us to make sure that the out-of-pocket payment pertaining to healthcare expenditure should be as low as possible. And if you could see, for Malaysia, the out-of-pocket payment for healthcare is a very small component of the overall household expenses. It was less than 2%. However, many households did not report any health payment, so there is some limitation pertaining to this, because more than a third of all households in all surveys actually did not report pertaining to whether or not there is any health payments. This is the limitations or the challenges that we face when we want to inquire such questions pertaining to how much they actually spend for healthcare. And with regards to the distribution of out of payment, OOP payments concentrated actually among the rich, and this is something that is not impossible, because this is something that we expected. And predominantly, the out-of-pocket payment was actually for the purchase of private care. And as you could see, it is among the richest quintile. And therefore, this is something that is actually good. So Malaysia and UHC, so far we could see that despite increasing demand for private care and expansion of private health sector, evidence suggests that Malaysia has actually achieved UHC. There is access to needed care, and there is good financial risk protection for health among the people. Of course, however, demographic and epidemiologic changes in the country may pose challenges to the maintenance of UHC, and this is not something that is peculiar to Malaysia. This happens in most of the countries. So let us look now at what are the challenges that we face in maintaining or sustaining UHC. As you could see, aging population is increasing even in Malaysia. Although currently the proportion of elderly is not that high, but there is potential for it to be higher. And this of course will impact or will have impact on the healthcare utilization, because we know that utilization of healthcare is higher among those at higher age group than lower age group. And because of the epidemiologic transition, there is additional non-communicable diseases to communicable diseases. Malaysia is now facing a double disease burden. We have existing communicable diseases which are still very challenging for us. That is especially dengue, also for HIV and hepatitis C. But now the NCDs are coming up, and all this is because of unhealthy lifestyles. In 2012, the mortality rates for non-communicable diseases are about 5 times the rate of communicable diseases. And this is evidence from the self-reported chronic illness, which was done or conducted in 2011. As you could see, the strokes and arthritis, commonly seen among the elderly, are increasing. And also the DALYS. You could see that DALYS, the change in DALYS over the years from 1990 to 2010 is increasing, especially on HIV and AIDS, as well as on other non-communicable diseases such as ischemic heart disease and stroke, diabetes, and other musculoskeletal diseases. And changes in mortality rates. Mortality rates had decreased for all age groups except for males aged between 25 and 44 years old. And the largest increase was for males aged between 35 and 39 years. And this is very worrying, because these are the reproductive age or the income generated population. The largest contributor to this mortality increase was actually from HIV/AIDS. And in 1990, 11% of all death among males aged 35 to 39 years was caused by HIV/AIDS. And this has increased to 33% in 2010. And the impact of this aging population and epidemiologic transition on UHC. In order to maintain UHC, the public healthcare system will need to increase its capacity to meet those increasing healthcare needs. And some indications that the public system is already overloaded, such as cases of patients bypassing the public facilities for private facilities due to long waiting times, and because of poor availability of essential medicines in public hospitals, leading to the need for patients to purchase from private premises. And this is very true for this year, when the economic downturn is very bad, especially for Malaysia because of the ringgit fall. There are some important medicines that are no longer provided by the hospitals, and especially affecting ARTs and some other cancer drugs. So the household out-of-pocket payments by expenditure categories in 2009, you could see that increasing, especially for dental outpatient and public inpatient as well as private inpatient. So if the public system is unable to cope, patients may be increasingly compelled to purchase higher price private care, even at the risk of exposing themselves to financial catastrophe and thus jeopardize UHC. And more cases will be unreported and missed. And this has been shown that, as you could see, the prevalence of non-diabetics, although is only 7.2%, but the actual diabetics prevalence is actually 15.2%. And this is very worrying. About 50% of the cases were unreported and not getting the right treatment. And less patients get access to treatment, as I have been mentioning just now, with regards to access of ART by the HIV patients. So how then are we to sustain UHC in Malaysia with all the problems that I have listed just now? Of course, I think the most important thing is that we cannot avoid, but we need to change the health system. The Malaysian public healthcare system has been credited to have brought about UHC in the country. However, the system's capacity to cope in the face of an aging society with its double disease burden has been called to questions. Thus, the country would need to invest more into the public system than is currently the case. Because, as you know, in 2011, the public sources of financing actually only made up 2.2% of GDP, or 6.62% of the general government expenditures. We need more investment if we are to make sure that UHC is sustained in our country. In fact, in the 10th Malaysian Plan, which included a call for greater development of the private health sector, albeit as an avenue for enhanced national economic growth, and that there should be greater collaboration between the public and private healthcare systems in order to allow effective delivery, greater efficiency, and affordable costs. Of course, with an element of cost sharing between patients and the government. We need to strategize for an acceptable balance between public and private provision of care in Malaysia, whereby provision of high quality care should be given by both public and private. We also need to consider a comprehensive package of healthcare services of which all Malaysian is entitled. Therefore, if it can be shown that the public healthcare system has indeed made such a package universally available, then it can be argued that this two-tier system will not compromise the UHC, since the private system is merely providing services that are over and above the agreed upon minimum package already available to us, to all. Thus, if a healthcare system dominated by private sector providers is deemed socially acceptable, then there are some merits to the recommendation of a social health insurance system for Malaysia. Actually, the Ministry of Health have been wanting to introduce the social health insurance in Malaysia over 3 decades. Mind you, over 3 decades. But they were unsuccessful. Perhaps the strategy that they used were wrong. Okay, maybe I will mention later what I mean by wrong strategies. At this point in time, it is not certain whether the proposed social health insurance scheme would prove to be more equitable than the current taxation base, as this is heavily dependent on the contribution rates, co-payments and benefits entitlement which have not been released. So Malaysia currently has no social health insurance. The Ministry of Health has been proposing to have social health insurance for the last 3 decades. However, they're still unsuccessful because of political interference and because of uncertainties pertaining to how much premium have to be paid and who is to be paying this premium. So in conclusion, Malaysia is a country where UHC has been achieved through an extensive public healthcare system, providing near-free comprehensive healthcare, financed through general taxation. And this is what I mean by we are very much different from Thailand and Indonesia. And this public system is facing challenges partially arising from demographic and epidemiological changes in the country, and also partially from the expansion of private provision of care. In spite of this, current evidence points to the continued maintenance of UHC in Malaysia. Nonetheless, unabated expansion of the private health sector has the potential to adversely affect universal access to care due to several inherent characteristics in the provision of private health care. And this, as I have been mentioning just now, pertaining to high user fees and maldistribution of private facilities, which favors affluent urban areas. And these unwanted effects may be accentuated in the coming years by socio-demographic changes in the country, especially by the aging of the population and the adoption of unhealthy lifestyles. This is where public health has to play their roles pertaining to preparing ourselves in overcoming the problems of the aged population, as well as overcoming the unhealthy lifestyles to prevent NCDs in Malaysia. Further improvement of the public system and maintenance of universal access to healthcare in the country will of course require public debate and consensus as to the future structure and organization of the country's healthcare system. With that, I thank you.